The goals for this talk are to discuss emotions and behavior of children with epilepsy, and for the rest of the presentation, because children with epilepsy kind of occurs a lot in the slides, I just abbreviated that as CWE. To summarize some of what is known about emotional and behavioral issues of children with epilepsy, to consider emotions and behavioral issues in the context of epilepsy as a brain-based disease interacting with psychosocial variables, and then to spend a good portion of the talk orienting toward action, things that can be done in terms of assessing to understand targets of intervention and steps that individuals concerned about issues of emotion and behavior in children with epilepsy can take or do. So this is a quote which I took from a book I like very much and actually have it at the bottom of the slides as a recommended reading. Lynn Bennett Blackburn is a pediatric neuropsychologist who's retired now but spent most of her career at St. Louis Children's Hospital and worked with epilepsy population for many years. And at the introduction of her book, it's called Growing Up with Epilepsy, A Practical Guide for Parents. She said, when you buy a new car, it comes with an owner's manual. At least once in their child's life, every parent wished their child came with a similar manual. In place of an owner's manual, parents often talk to friends or seek guidance from their own parents. But when your child has epilepsy, this informal network fails you. Friends and family members often lack the experience necessary to be helpful. The unpredictability of seizures and the potential for side effects from medication often result in confusion about what's fair to expect from a child with epilepsy. Confronting the misunderstandings from others leaves parents in the role of epilepsy educator, a role that they may not really feel prepared to undertake. Each stage in a child's life presents unique challenges that may range from, at earlier years, arranging daycare to issues with school programming to driving and some of the transitions that typically occur for many around adolescence and young adulthood. It's important, and I put it in bold, to emphasize that children with epilepsy can grow into independent, effective adults. To do this, Lynn said, and I think it's really very true, they need discipline to build appropriate behavior, which discipline is often a way of teaching, social skills so that they will be accepted and can function in the world, and the educational background that provides the basis for their eventual employment. So I'm going to talk a little bit about some of the things that we know, and this mirrors some of the comments made by Dr. Jensen's talk this morning. Children with epilepsy have behavior problems at rates that are almost 5 times higher than children in the general population, and about 2.5 times higher than children with other chronic medical conditions that don't involve or affect central nervous system. As a group, children with epilepsy have higher rates of behavioral disturbance and psychiatric diagnoses, probably linked to what Dr. Jensen was talking about just before, that we're talking about things that the central nervous system or brain, these are symptoms of dysfunction in central nervous system. And one of the manifestations may be epilepsy, other manifestations may be a group of conditions that we label as psychiatric conditions because they're what happens when there's something going wrong in central nervous system. This is a meta-analysis. The reference is kind of up at the top, but a meta-analysis is, we'll pause for a second and say, in a lot of science, there are individual studies which make their best effort to kind of address a question or problem. But before you start to believe things, there's contradictory findings. One study finds one thing, one study finds another. One of the approaches that is taken to get past that is to start to do what's called a meta-analysis, where people will look at a whole collection of studies that have addressed a similar core question, and they'll try to look across those for common themes in the results. So I pulled from this because it's a meta-analysis of 46 different studies involving almost 2,500 children with epilepsy. In general, children with epilepsy display more attention problems and, psychology word, internalizing problems, meaning things like withdrawal, somatic or kind of minor physical complaints, anxious and depressive symptoms than they do kind of acting out or externalizing behaviors or conduct problems. This slide is an attempt to compare the kinds of behavioral issues that are common to children with chronic health conditions and to highlight those that seem more specific to children with epilepsy. So in the column to the left, children with chronic health conditions have more issues with withdrawal, somatic complaints, depressive symptomatology, delinquent or more like acting out conduct problems, and aggressive behavior than might be seen in healthy peers. And that's combining groups of children with asthma, diabetes, other chronic health conditions, but separate from epilepsy. Children with epilepsy share a heightened level of those behavior problems, but there's relatively specific to children with epilepsy is an elevated risk of attention problems, social problems, and what they call thought problems, but they are individual symptoms or some small pattern of symptoms of a variety of psychiatric conditions. And so it is likely the case when you think about this that it has to do with the brain bases of epilepsy and its impact on the circuitry that regulates and controls attention. Our ability to engage and sustain social relationships has a lot to do with our understanding of emotion, our ability to recognize that in others, our ability, especially at older ages, to anticipate how someone else might be feeling in a situation, to modulate and regulate our behavior in response to that. It is a complex, these are among the more complex things that people do, and thought problems is a kind of a really comes from a label of one of the instruments, but it's a collection of symptoms that may involve things like engaging in repetitive kind of behaviors that may help lessen anxiety but have no functional purpose for the individual, instances where the individual may have patterns of thought, like I guess compulsive patterns of thought, or other individual symptoms of psychiatric disorders. So there have been a number of studies that have tried to understand the incidence of behavior problems that are present at early points in the diagnosis of epilepsy. So there was a study that was done across multiple institutions. The interest was looking at behavior problems at the time of a first recognized seizure, so early in the course of the life of a child with epilepsy, and changes out over the next 3-year run of time. They looked at some prior work which had found 2-year prospective study, meaning going forward study, looking at new onset of seizures was associated with an increase in childhood behavior problems. They were the things that led to or were associated with more behavior problems were decrease in parental emotional support of the child and decreases in the parents' confidence about their ability to discipline their child. And I think that relates back to what Lynn said at the beginning. I think having a child with epilepsy can throw parents off their game a bit. They don't know if she has a part of the chapter, she talks about the demon at the dinner table. And if the child's misbehaving at the dinner table, many parents would feel quite comfortable addressing what is inappropriate behavior. But in a child with epilepsy, you don't know if you're dealing with, is this a medication side effect? Could this be a seizure? Or is this just bad behavior? And that you end up thrown off your game a little bit and unsure of how you should be responding in this situation. And we'll talk some more in other slides about this, but it's one of the recurring themes. And a reason why I think it is important, those things that Lynn mentioned at the beginning, I think are very important. Education, understanding for parents of children with epilepsy is important so that you do feel like you have confidence in your ability to manage the situation, that you have some sense of questions that you should be asking, things to be looking for, but not taken out of the role of parent of the child, because that is a very important way that children learn. I mean, if you think about If you think about a child who had no parental influence, no adult guidance, they really do kind of run amok. A way that you initially learn, and really before your frontal lobes come online in terms of regulating your behavior, a lot of the early regulation of your behavior comes from the structure of those who are around you. And they help you to understand where the line is and what you should and shouldn't be doing. As you get older, a lot of the challenge of growing up and the maturation of your frontal lobe, allowing you to take that control internally, is regulating your behavior internally rather than externally. When I was 2 or 3 and out with my parents, I didn't know any better than not to start talking, I don't know, in the middle of church. The external structure around me helped me understand that that was not acceptable in this situation. By the time I was a bit older, there was a growing expectation on my parents' part and my own that I could recognize the situation, I could inhibit asking a question, I could wait to do what I wanted to do until the situation was more appropriate. But if parents are out of their comfort zone and not feeling able to parent their child, there's a series of downstream consequences. There have been separate prospective studies. Maladaptive parenting, or really the parent kind of out of their role, was the strongest predictor of behavior problems 3 to 4 years after a diagnosis of epilepsy. So in their study, they found 300 children with epilepsy aged between 6 and 14 who were identified at their first recognized seizure. They had 196 healthy siblings and followed the group out for 3 years. Children with a prior unrecognized seizure were actually more at risk for behavior problems. So when they would, ask about the history, and it's like, looking back, now I wouldn't have known that was a seizure, but probably that started a few years ago. That group was at higher risk for behavior problems. Across the whole group of children with epilepsy in this study, behavior problems actually decreased over time. This was a group that was a heterogeneous group, the majority of which, if you think about the majority of children with epilepsy, their condition is really treatable. And so that with medication, they may have a real effective reduction in seizures. For some subset of individuals, that's not the case. But there, as Dr. Jensen was mentioning this morning, we really are talking about a continuum. And in this group, many of the children's epilepsy was very treatable and amenable to treatment, suggesting that the getting past the initial diagnosis, gaining information, being able to accept this reality of the child's life and move forward is really important, both for the child's outcome and well-being and probably for the parent and families as well. There was more behavior problems in children with epilepsy than siblings, and consistent behavior problems in their 3-year follow-up study were present in just 11% of the children with epilepsy. So at an elevated level relative to the to children without a history of epilepsy, but in a minority of the group. The key risk factors for more behavior problems were less caregiver education, and in many of kind of psychosocial studies, parental education is a marker for a lot of things. It's not just necessarily about the amount of schooling completed, but it also often links to occupational status, resources available. It comes up in a lot of studies, and it may not just be about the grade level that is completed, but it probably links to a lot of other variables that influence resources available to the family system. From the child's perspective, slower initial processing speed and slower processing speed over testing across the course of those 3 years was associated with increased behavior problems. And a number of family variables were associated with more behavioral issues. Lower levels of family mastery, and it's kind of another psychology-ish term, or at least in this literature. It really means the family's ability to kind of be organized and pull together to accomplish shared goals. So it's like we're all in this together, and the unit of the family is kind of working together to meet the needs of the group. So lower levels of that and lower levels of the child's satisfaction with relationships in their family is associated with more behavior problems. Lower parent support of children's independence and autonomy was associated with more behavior problems, and lower parent confidence in their ability to discipline their child was associated with more behavior problems. So there are some consistent themes that come from across studies. This is an attempt to, and really the next slide is the one I mostly want to get to, but this study was an attempt to look across, again, multiple studies and try to integrate the literature a little bit. They were trying to identify factors associated with behavior problems and psychiatric disorders in children with epilepsy and group them into illness-related variables, psychosocial variables, and then trying to model how those might influence the occurrence of behavior problems. So this is a little bit of a busy picture, but if you look to the column all the way to the left, there are, these are the kinds of stressors on the system. So family stressors, including from the effect of epilepsy itself, other stressful events, because it may not be the only thing going on in life, psychopathology or in a family member as an additional stress, characteristics of the epilepsy being experienced, the seizure frequency, the type of epilepsy, the age of onset, the duration, anti-epileptic medications and their effects, and other comorbid deficits that the individual might have in terms of cognitive or linguistic skills are one component, and really taken together are kind of the illness-related variables and the stressors that are present in the family system and in the child's life. Then you start to think about the things that may interact with those stressors, the resources that the family has, both in terms of socioeconomic resources, which makes a lot of things easier in life or harder, the extent of social support that they enjoy from extended family community that they're embedded within. Are they relatively isolated and don't have people to draw on to support them, or is there a rich network of support around them? Mastery and family routine, so is this family pulling together in an organized fashion, has basically their stuff together, and they're working effectively together. Esteem and communication, so do individuals in the family communicate through their behavior and words a degree of regard and appreciation of the worth of the individual? And family cohesion, which is really kind of related to family mastery, is this group kind of really pulling together and working as one unit. Individuals' coping strategies in terms of parent-child interactions, expressed emotion, or is there a parental kind of distancing or rejection of the child, kind of a stepping back that is part of an individual system? From the child's perspective, what is their sense, locus of control? There's a lot of psychology words in this, but it has to do with, do you think that you basically have an influence on the way things are going or not? Are you just a little cork bopping around in the sea and there's nothing you can do to change events and you're just getting basically smacked around by the waves that come and you really have no ability to chart your own course? Or do you feel some independent agency, and that if I set an objective, if I have a goal, I can actually accomplish the things that are important to me? Can I have an effect on the world that I'm living within? Is the child developing a sense of competence? Is there a degree of irritability? To what extent are they feeling different from other children? And then perceptions, parent and child beliefs and feelings related to the fact of epilepsy in their life, epilepsy characteristics and the comorbid deficits they may be experiencing. All of these things, and the arrows are their attempt to try to model how this might play out, but the big idea is that there's a bunch of illness-related variables and where you were sitting, how you were riding in the water before this happened, before epilepsy entered the situation. Then a whole bunch of things about the family system, the resources, the strengths, the weaknesses, the child, how they're responding to the fact of the epilepsy that help influence what, in the end, is the family's level of adjustment and to this combination of circumstances and to the existence of behavior problems in the child. This is, I think, important because, and the next slide is going to be a little bit more biology, but this morning's talk, I think, was fascinating and is, I think, helps us from a world-renowned expert really understand brain development. But I want to remind people that a brain is not in isolation. A brain is in a child, and that child is living in a world and a family, and there are interactions of the experiences that you have growing up that then feed into the biology, because we're experience-dependent organisms, and our course is also influenced by the experiences that we have, and that comes to be reflected in central nervous system as well. So this was, which comes first, psychopathology and epilepsy? Is it the chicken or the egg? And Dr. Jensen alluded to some of this in her talk this morning, but in population-based, and these studies really come from Scandinavian countries because they have one kind of healthcare provider and an entire population can access to data about everyone in their system. So in a population-based case control study of all newly diagnosed unprovoked seizures in all of Iceland for children and adults from 10 and up, so they take a person who would manifest their first seizure, and the case control part means they went back to the birth registry and they found the people who were born right next to that person in order, as basically someone growing up in their same society, born almost at exactly the same point, who didn't have epilepsy. They did standardized interviews to assess for the existence of psychiatric conditions using questionnaires keyed to the major classification system. They found that an individual who had a history of that there was, for individuals who had their first unprovoked seizure, there was a 1.7 times, almost 2, 1.25 times more likely to have had a history of major depression prior to the manifestation of their first seizure. If there had been a suicide attempt, there was, the individual was a 5.1 times more likely to have had a history of a suicide attempt before their first unprovoked seizure. It is really getting to the point that there may be common biological mechanisms underlying. Next slide is, this is also from Sweden, Scandinavian countries. They looked at about 1,800 people with epilepsy and about 15,000 controls and developed what are basically your odds ratios or your risk. The risk of developing an unprovoked seizure was highest less than in the 2-year period either side of having a first psychiatric diagnosis. That included, and relatively comparable rates for across a number of psychiatric diagnoses. So there seemed to be something about biologically the risk of developing psychiatric diagnosis is also linked to the risk of having first unprovoked seizure. And so it is, I think, helping us understand, as Dr. Jensen was saying, that there may be some common biological mechanisms underlying this, which is, we think about these in different categories sometimes, but they're really about central nervous system and its functioning, and may provide clues into novel approaches to treatment, common mechanisms, and interventions. So I want to focus now on things that people can do and act upon. So I liked this slide. I just Googled act and action changes things. So I like that. There is in 2011, there was a major consensus statement on clinical practice for the treatment of what's called neuropsychiatric, so a psychiatric or behavioral kind of concern associated with epilepsy, and the recommendations are specific to children. Consensus statements really are pretty much settled. These are not controversial. This is really when they gather a panel of experts from, in this instance, all around the world together. These are things that people are pretty sure about. The assessment and management of psychiatric disorders in children and adolescents with epilepsy requires a careful assessment of behavioral and psychiatric disturbance to understand its cause and course. So it is important at the individual level to conduct a careful assessment. There are different causes, and they require different management strategies. I mean, this is not, you need to consider the individual. You need to try to understand this situation specifically and what may be drivers of. You should consider the epilepsy itself, the treatment of the epilepsy, reaction to the fact of having epilepsy, and associated brain damage or dysfunction as possible causes of the psychiatric disorder. You need to look at the anti-epileptic treatment, and it's often the first step in trying to manage behavioral or psychiatric disorders, as some medications are associated with more behavioral side effects. Specific psychiatric disorders such as depression and anxiety and ADHD are more common in children with epilepsy than the general population, and for this reason, you need to first exclude or manage the issues that are related to the epilepsy, But if that is not, if you still have significant symptoms of anxiety, depression, ADHD, you need to take advantage of standard treatments that exist for those conditions. About 30% of children with epilepsy also have ADHD, and about 70% of those will respond to treatment of that condition. Sitting in a pediatric setting, that's often a comorbid diagnosis. I mean, that number's about right. And there is sometimes a reticence on parents' part to undertake medication treatment of ADHD with the feeling that they're already on so many medicines. But I encourage people to think about a little mental seesaw, that if you recognize that your child has clinically significant issues with attention and impulsivity that are impacting their ability to profit from instruction in school, are impacting their peer relationships, mean that most of their interactions with you are around do this, don't do that, stop doing that, put that down, that they're having a constant stream of negative interaction, you have to consider the risks of leaving that condition untreated, as well as the risks that it's appropriate to consider about medication, but you need to have your eyes open and consider both sides of the equation in making your decision. Autistic features are relatively common in children with epilepsy, but relatively uncommon in those who don't also have some evidence of other cognitive dysfunction or learning problems. It's particularly important to exclude or manage epilepsy as a possible cause. Depression is underdiagnosed and maybe underrecognized in children and teenagers with epilepsy, emphasizing the importance of screening for those conditions. And that's probably true across a lot of pediatric conditions. There is, at CHOP, there's an increased emphasis on embedding those kinds of screening into well-child visits just because of the high base rates and the relatively unrecognized, the fact that it goes unrecognized. Depression and anxiety in children and teenagers can be treated with cognitive behavioral therapy, but medications, including the class known as selective serotonin reuptake inhibitors, should not be withheld if indicated, since these drugs don't seem to exacerbate seizures and may even be protective. There is certain medications that impact anti-epileptic blood levels, so the prescriber needs to have a knowledge of what they're doing, but hopefully you're in the hands of people who have that degree of expertise. Psychosis is uncommon in children with epilepsy, but can occur in adolescents. Treatment with the lowest level of neuroleptic medication is unlikely to present a serious seizure exacerbation. There are some exceptions and medications that some degree of provider expertise that's necessary. Epilepsy may lead to teasing and bullying, and combined with limitations that the individual are already placed on the individual because of their epilepsy, can contribute to behavioral disturbances. And there is an importance to managing the whole child within the context of their peer group, their school, their family setting. That's, and this international consensus agrees, is an integral part of essential and a good practice, but I think sometimes often gets overlooked. I had a few more slides that I want to leave some time for questions. I'm not sure in the modified time schedule what I should be aiming for. Okay, so let me, I put in a few cognitive slides. As a neuropsychologist, I feel like I have to talk about cognitive issues, but I'll skip through these a little bit quickly. Basically, the slides are in the handout, but in a child with epilepsy who also has cognitive issues, it's important to try to understand is this really the individual's level of functioning, or is there something about their current seizure burden, something about the side effects from the medication that they're experiencing, something that's basically treatable? Because if you can modify some of those some of those factors, the individual's cognitive functioning may be markedly improved. So it is important to always make that assessment and engage in that discussion with the providers to look for things that are treatable. The other slide, which I think is important, that you should not be expecting the child to go backward and lose skills. If that is the case, that is kind of an indication for some evaluation of what is going on in this situation, because children who lose skills without an obvious cause, a bell should be ringing somewhere, and that's an indication for follow-up. I'll skip that. So I wanted to talk a little bit more about family factors, because the more you know, I think the more you're able to do. This was a literature review across 35 studies, 1,400 kids with epilepsy and their families. not a settled area. There's a lot of opportunities for research, and a lot of the research strategies have been relatively simplistic and don't quite mirror the complexity of the way all of the interactions that occur in real life. But there are a few takeaway messages. Compared to parents of healthy children, parents of children with epilepsy appear to have more difficulty around limit setting, can be favoring or over-nurturing of the child with epilepsy. And that may not just be specific to children with epilepsy, I gotta say. I remember one of my first ever treatment cases was the parent of a girl who had leukemia, and she said to me, pretty much quote, "I made a monster." She said, "I can tell you exactly how I did it, and I'm here to undo it," because for 2 years of her treatment, whatever she did was fine. Whatever she wanted, she got. Any question, the answer was yes. And basically, at the end of treatment, she was healthy, but basically her mom said, "I've made a monster," and really had to kind of turn that back. Inconsistent parenting and providing emotional support to the child are important in influencing the development of behavioral issues. So children with epilepsy and psychopathology, so children with epilepsy who also are manifesting psychiatric conditions, compared to children with epilepsy without psychiatric conditions, regard their moms to be more overprotective and fathers to be maybe more harsh and less supportive. Generalizing across studies, and these don't speak to every individual instance, but that is kind of, when you look across studies, that seems to be a theme. And you may see, like at reading these and typing these in, I was thinking about families I've seen over the years where that maybe there's an attempt in the system to strike a balance. The father may see one parent may see the other being overly permissive, and they figure, well, we'll balance that out with the other. I guess speaks to the complexity of the system, because these are not independent factors. The one parent is seeing the other parent interacting with the child and may be adjusting in response to that. Children with epilepsy's rating of parent psychological over-control was, and this is, they talk about psychological control is probably not the best way to get what you want your child to do. So it's withdrawal of affection, kind of using your emotional regard for the child as a lever to get them to move the way you want them to, is really associated with poorer outcomes for the child. Higher levels of depression, impulsiveness, home and school problems, when their experience has been basically their emotions are getting played a little bit in order to leverage their behavior. Parental depression for themselves, decreased confidence in their parenting ability, and increases in stress seem more associated with higher levels of behavioral issues or psychopathology in the child. So I think from a parent's point of view, taking care of yourself, making sure that you are attending to your own well-being, taking the steps that you can to feel like you have an understanding of what the issues are and the skills you need to be effective in the very important role of parenting, and drawing on the resources that may be available to you to manage stress of life, and including life of a parent of child with epilepsy, may be important in helping that child function in the future. Getting past the stress of initial diagnosis to acceptance of the child's diagnosis appears to be an important predictor of child-parent attachment problems, which in turn is a big predictor of child's behavioral issues. Positive parent-child relationship quality and parental support of a child with epilepsy's growth and independence may play an important role in preventing emotional and behavioral problems. Again, when I typed that, I was thinking I saw 2 children in a week. They were about the same age. Looking at their neuropsychological profiles, you could have switched one for the other. It was very similar. One child was growing up, was the son of an attorney and a physician. The other was a single parent who, I forget what she did, but didn't have a lot of resources available to her. And the child growing up in the parent and attorney family was probably among the most bubble wrapped, like protected, limited, like that basically they cared about their child immensely, and they did everything possible to protect their child. And I think if they could have like put him in a nest and sat on him, they might have. The other mother said basically she was pretty plain spoken. She said her family thinks she's crazy because she lets him ride his bicycle, and she makes sure he wears his helmet. But she said if he doesn't get out of the house, either I'll kill him or he'll kill me, is what she said. And so she I remember they lived next door to an auto body shop, and he used to go next door and they'd give him $1 to crush boxes, and it was. When I sat back and was thinking about these, you'd think going into the situation, the highly educated, more resourced family, I think that kid was probably in a tougher spot because he was not getting the experiences of going out in the world. That other kid having some work experience. He was, the mom said she asked them, is he bothering you? And they said, no. When he gets old enough, tell him to come back. They'd like to hire him. Like he was getting, his mom realized she was taking a risk and felt like pressure from her family about it. She was letting him go out and be in the world. And I think that was probably healthier from that child's development, but more stressful. So this, I think, is the last slide that I put in here aside from the references. I want to remind people that we are talking about a brain, and a lot of today's discussion was about brain. But that brain is not like a thing in a lab dish. That's a brain inside a child who has epilepsy, who is behaving in and learning from their interactions with the world. And those interactions are in turn influencing the course of their brain development. So brain development, this is not a laboratory like experiment. These are people living in the world, and their experiences in the world interact with their growth and development of their brain, and the outcome when you get to thinking about their ability to manage and regulate behavior, the occurrence of psychiatric conditions, or when they do occur, how those get responded to. And then I had some recommendations from the Epilepsy Foundation's website, Seizures in Youth, and then I really do like Lynn's book. I feel like I should buy a case of them and sell them out of my office because I've suggested it to a lot of people. Thank you very much. Thank you. Yeah. And in my report template, I have a little paragraph that I often have. A challenge is, how do you advocate effectively for your child while maintaining working relationships in the long term? Because that is the knife blade on which you dance, that you are your child's advocate. They're not able to developmentally, they're not even going to get in the room as a little kid into the discussion. They don't understand it. You are the carrier of the information. You are the person in the world most vested in safeguarding their developmental course, their access to needed services. But how do you do that without, basically starting a war? And that is...
It's very unfortunate, but when you're confronted with the, even sometimes the wraparound care, it's sometimes, they come in to try to help, and yet the therapist, I'm like, do you realize he has apraxia? Do you realize he has a sensory integration dysfunction? He can't self-regulate, and you're screaming in his face. Is that going to get him to stop?
And
you can't give them basically the intervention. You need to give them the skill first. Then you tack on the intervention. Because if they don't have it, it's never going to work.
And the place where, and I don't know if it would work in every situation, but there have been, in my experience, there have been multiple instances where I think school sees the words and they don't really exactly know what all that means. And so they jump past that to what to something that they think they know. And a real effort to help them understand the meaning, it was an epilepsy instance, but in training I was a young man, his family probably had a difficult time advocating for their son. He was about to repeat ninth grade for the third time, which was not a good situation. He had a series of strokes, and among the reasons they were failing him was because he couldn't complete the rope climb in gym. He was weak on one half of his body, and so it is, and I think when I went to I drove 3 hours to go to his IEP meeting because I was a trainee and had a lot more free time. I didn't have as much control over my time, and I was like, so I drove 3 hours to go to his IEP meeting, and the teacher's response was they had no idea. This was all in the paperwork, but they really didn't understand, and it's somehow getting it from the paperwork to their understanding of the situation in a real kind of way. I'm doing something actually in a report I need to finish, but I talked with the parents about it. This child looks completely healthy. You wouldn't know anything's going on. There is a chunk of their brain that is gone. And so we actually talked about me putting a clip of the MRI in the report, because the teachers have formed a lot of attributions about what it is and why the behavioral issues and their own, that it's willfulness in a variety of regards. And I really don't think that is the case. But how do you crack the little shell so that they have an understanding? Because I think, and I guess I would trust that if people understood, they would respond more appropriately. And so sometimes I think it's really, how do you succeed in communicating in a way that they can hear and the information in a way that's effective?